it's not for the beginner to use this. Look again, before you go to far periphery, you can start the aspiration using phaco tip, and then the flow will bring the epinucleus to the phaco port, and you can remove the epinucleus quicker than you do with the IA tip. But for beginner, it's better to do the epinuclear removal using the IA tip. While you pull the cortical material, the epinucleus will fall together with the cortex, and then you can remove the epinucleus together with the cortex. This is another case of epinucleus. You do again the hydrodissection. This is the case when you already remove the nucleus and the epinucleus left with the cortex, and you do hydrodissection again, and the epinucleus will pop up outside the bag, and you can aspirate using IA much more easily, like this. So with the cortex aspiration technique, we have to start somewhere else, leaving the subincisional cortex to be removed last, because that's the most difficult site. We have to turn the port facing the rexis edge in every position, and then collect the cortical fiber until the port is occluded, and then you use low vacuum first, just enough to pull the cortex toward the center, and then you increase the vacuum at the center to remove the cortex. By this pulling technique, the cortex will be pulled and peeled from the capsule. It's cleaner than if you increase the vacuum very close to the rexis edge. So when you remove the cortex in this side, and then you can continue with the remaining area. But remember to face the port to the rexis. So at the side you have to sideways like that. And when you are reaching the subincisional, you have to face the port downward to the edge of the rexis, and then when you catch the cortex, you can face the port upward and then start to pull. This is like this. You start and then you peel, pull, and then increase the vacuum, change the position, and pull. And the remaining subincision will be removed last, facing the port inside, and turn up, and then pull, and then increase vacuum in the center. I prefer to use the straight IA, but in some case you may want to use the like a bent or like right angle IA tip, but right angle IA tip may be good for the subincision, but for other part of the cortex, it comes in. I don't like it, so that's why I use the straight IA tip with the turn up and then pull.
I agree with you, but then the other thing I would like to point out is he's using the IA tip with the silicone sleeve, which I think is very important for sealing the wound so that your chamber remains deep. In SNEC, the nurses sometimes try and save money, and they give the residents the metal sleeve, which is free.
Yeah.
And then it leaks and the chamber is unstable, especially when you're trying to reach subincisional cortex. So don't let your scrub nurse bully you. If they give you a rigid sleeve, ask for a silicone sleeve like that. You seal the incision much better.
Yeah, right. And this is another case. Maybe you can have the small fragment of the nucleus left somewhere, and when it comes to the port, you have to use your spatula to crush against the port to remove that, and then you can continue with the remaining cortex. Let's see again that you can just engage and pull. The pulling will peel out the cortex cleaner. But in loose sonul, sometimes you have to pull tangentially to reduce the force that you directly put to the sonul. But in normal sonul, you can just pull right away toward the center, like this. In sub-incision, you can use the combination of 27 gauge needle and the insulin syringe 1 ml. The small syringe system has a very strong vacuum inside that it can produce. It can use to remove, but this must be under viscoelastic. You remove the sub-incisional. Let's just see again for this. Pull, engage, and pull, and increase vacuum in the center. Okay. This is cortical cleanup in loose sonul cases. You have to avoid pull too fast. That will put more stress to the sonul. You have to pull gently and with not too big bite. You have to pull very small portion and pull slowly toward the center. This is with the CDR, so it's more difficult with the CDR in place because the CDR will catch the cortex. So you have to sometimes use the spatula to countertract at the edge, and sometimes this end of the spatula can push against the CDR just to help reduce the sonular stress. So in case that the sonul is very loose, we have to place the CDR from the beginning, and we will have these problems of the cortical cleanup. But we can slowly, gently, and use countertraction, try to pull, and sometimes we pull tangentially just to reduce the force, and slowly like this. Okay. And in the case with the loose sonul, remember that the fluid that you infuse into the eye can also enter backward into under the posterior capsule and make the posterior capsule floating against the IA tip. Sometimes you have to use a viscoelastic to help to push the capsule away, or sometimes you can use the IA tip just to press the posterior capsule and squeeze the fluid under that come forward, and you may have some more seconds to grasp the cortex and pull, and you may have to repeat that maneuver many times before the cortical cleanup can be completed. This is the case of coloboma. The cortex in this, the sonul in this area is compromised. We have to pull the cortex in other area first, leaving this area last. And also we have to remove sub-incision just before remove at the area of coloboma. And again, you can see this is the remaining epinucleus, thin layer of epinucleus that you can pull together with the cortex. Because you cannot pull the epinucleus. Epinucleus nature is not a fiber-like, so you cannot pull the epinucleus. You can pull the cortex, and the epinucleus will come with the cortex. And then you see the capsule push forward. So I use the IA just to press the PC to squeeze the fluid out, and you have maybe 5 seconds to catch the cortex, and the capsule will come up again, and then you have to repeat that this pressing, you see, pressing, and then you can catch attach the cortex and then repeat that. And this is the last piece. You can pull gently and sometimes tangentially for the remaining piece. This is the diagram that I already showed you that this can happen. This is the bimanual IA with the irrigation from this side and with the aspiration port from this side. Can switch between the two sides. And also the next case we use the same, so you can switch between left and right much more easily. But this one irrigate more fluid and it's better. You see, we have like more leakage with that metal tip without any kind of sleeve. But it's okay, can still keep the chamber deep enough. And this is the side incision, turn back, turn down and rotate up and then pull. This is the case that we can use the two aspiration tip that can be simultaneously switched over between the two sides. For the capsular pollishing, you need to know some fluidics. In the capsule pollishing, this is sometimes the most dangerous part because sometimes if you use too much vacuum, you can catch the capsule, and once you catch the capsule with a stronger vacuum, the capsule will go maybe too much into the port, and when you move the IA tip, you can break the capsule. So we have to use not so much vacuum, and also you have to notice that the bottle height is also determine the vacuum. If you, during the IA or capsule polish, raise the bottle height too high, when the tip catch the capsule, you try to vent by depressing the foot switch, but the venting may not be enough to push the capsule away. Then you can have the rupture. So I will set the bottle height to about 30 centimeter above the patient's eye, 30 centimeters. That's enough to irrigate the anterior chamber during the capsule polishing. And even during the IA, with the vacuum around like 400 or 450, the irrigating with the 30 centimeter is okay. Normally, we are taught to use the bottle height of like 70, 80 or more than that. Maybe that's too much. I can prove that with the changing of the height of the bottle, you can create the pseudo vacuum by the leakage of the fluid pass through the port outside the eye. By detaching the aspirating line, you can adjust the vacuum, that pseudo vacuum, but it's not a pseudo, it's the real vacuum, by changing the height. This is the proof. I detached the blue line with the aspirating line, and you can see the fluid leaking coming out from this. And you can see inside the eye, the port can catch the capsule with some fold. But you can move without damage to the capsule. And you see the irrigation in this case is 50, but it's better to be 30. This is a safe passive aspiration technique. In this case, we can use the three-way stopcock. When you want to do the passive, you just turn the three-way valve to allow the fluid to leak here without using the pump. and you can use the pseudo low vacuum for the capsular polishing. But if you encounter with some fibrosis or some cortex that left in the posterior capsule that will be not enough for this pseudo, you can switch back to the active aspiration, the normal aspiration, and do more polishing. So the passive is also safe, but if you use the active with the bottle height of around 30, it's okay. So let's see the last video. This is the passive IA for the small remaining cortex, and then switch to active using the three-way stopcock, and then the cortical cortex can be removed. This is the passive, and then switch. But this is just only to prove that passive aspiration just exists. But it's maybe take some time to, if you have to switch back and forth the active and passive. So in the real life, you just use the active aspiration with the low bottle height. That's all the message that I want to give you. With the lower bottle height, with the IA, I never experienced the collapse chamber, and also with this silicone sleeve. So during the IA, I prefer to use a lower bottle height. In this case, debris under the IOL, we can use the IA tip to go under the IOL to remove some debris. That may be cortical fiber or small nuclear fragments. Some surgeons also prefer to remove the viscoelastic that left under the IOL just to have a good, better centration or reduce the PCO, but I'm not believe in that much. Normally, I don't remove directly by go under the IOL. I just press the IOL downward to squeeze out the viscoelastic under the IOL, then remove in the front of the IOL. Thank you very much.
Thank you very much.